Adolescents and Spirit Hubs, and we're really delighted to have Greg Ahrens here today, who's a lead thinker in implementation science, both domestically and globally. The leading thinker, I think. And the leader. Greg is a clinical and organizational psychologist. He's a professor of psychiatry at UC San Diego and director of the Child and Adolescent Services Research Center. His research has been funded by a range of NIH institutes and major foundations, and it focuses on identifying and improving system, organizational, and individual factors that support implementation and sustainment of evidence-based practices and quality of care in health and allied healthcare settings. His work on the leadership and organizational change for implementation, or LOCI strategy that he'll talk about today, is being used and tested in settings focused on mental health, schools, child welfare, HIV prevention, and trauma care in the US, Norway, and West Africa. And his highly referenced exploration, preparation, implementation, sustainment, or EPIS implementation framework is used in many settings globally, including in our scale-up hub, Youth Forward, in Sierra Leone and Liberia. So we're really thrilled to have Greg here today. He'll be talking about developing and testing implementation and scale-up strategies to improve health, and we're delighted to have you.
Well, thank you. So thanks for calling me a thinker. Hopefully I'm a doer also, because for me, that value of kind of taking these theories and really making a difference in different settings is kind of critical and important. So I will use the mouse. Here we go. So as you mentioned, been funded by that I do. It takes a lot of collaborators and collaboration. So just want to acknowledge a number of those folks. And also it's very multidisciplinary, interdisciplinary work. And we have a paper under review talking about what it takes to develop team science for dissemination implementation research. And so we're really kind of interested in bringing together different disciplines to solve some of the thorny problems that we have both domestically and internationally. So what I'm going to talk about today, I'm just going to say a little bit about implementation science and talk about the EPIS framework, the LOCI strategy that Teresa mentioned, and then the scale-up strategy, the Interagency Collaborative Team model that we developed here in the US. And often this question comes up, if we develop something domestically, can it go to scale? Can we use it in other settings? Can we use it especially in countries that are low and middle income? But also I want to say that, there are things we can learn from work in developing countries that we should bring back, especially around what it takes in terms of collaboration and really engaging with the systems and people that we want to work with. So, and then I'll talk about the ICT work that we're doing just briefly, and Teresa will let me know if I'm getting anything wrong or if I need to say something more. So, so why do we care about implementation science? And implementation science, we call it an emerging field. I began in implementation science over 20 years ago with, I think, one of the first or second R1s to come out of NIMH with their D&I announcement. But all too often, there's so much work being done in intervention development. It's the huge funding portfolio of the NIH, of other research bodies, but really much of that doesn't go to the benefit of patient care, doesn't go to the benefit of practice in communities. And so implementation science has really grown to address that gap. And it's a pretty huge gap. If we look at implementation failure rates, about 55% for home-based mental health treatment, implementation failure, TQM in healthcare, citing things like management and practitioner resistance, lack of commitment, the culture of organizations, which are really hard to shift. Failure in implementing justice in policing, need to encourage openness about evidence-based knowledge. Implementation failures in healthcare range from 30 to 90%. And we were talking about this last night at dinner. One of the best examples that I have is the issue of hand hygiene. Began with Ignaz Semmelweis in the mid-1800s around OBGYN care and women illness and dying from unsanitary conditions. Today, in 2019, we still only have about a 73% compliance rate around hygiene. And I've seen this you know, when I'm doing walkthroughs in hospitals and things like that. So we haven't made it yet. So implementation is something we really need to pay attention to. But in a lot of our work, we talk about the role of leaders and leadership, setting the stage for implementation. And that should be a theme as I talk through both the LOCI model and the Interagency Collaborative Team model. So what's an implementation strategy? It's been described by Enola Proctor and Byron Powell as methods or techniques used to enhance the adoption, implementation, and sustainment of a clinical program or practice. So it's how do we go about implementing it? And often people think, oh, well, we need to implement cognitive behavioral treatment. How do we do that? We send our staff to training. They'll come back and be able to do it. Well, if we look at what's actually going on in practice, we look at case notes, documentation, audio and video recordings of what they do, we know that quickly there's a drift away from Fidelity, and often you really lose the core elements of a practice, so you're not getting the health benefit. In contrast to implementation strategies, scale up is really thinking bigger, right? So how do we take an EBI, evidence-based intervention, that's been designed and implemented in one setting and proven, you have implemented, and then how do we scale it up? How do we really bring it to scale in a larger system, a health system similar to where it's been developed? We're really thinking about impact with scale up. So I'm going to be talking about an implementation strategy and then some scale up approach as we go through this. So in implementation science, it's important, especially for grant applicants, to think about your theoretical framework. So it's not enough to say, well, I think this strategy is going to work, but really to bring in theory. Now, the problem with this is, as Rachel Tabak and colleagues identified, they reviewed over 61 frameworks. There are more than that. So a lot of what happens in the field is that, especially with junior investigators, is how do I select a framework? How do I select a theory? And I think it's a combination of understanding the theories and frameworks that are out there, but also your experience in the setting where you want to implement or bring about change. And I can't stress this enough, to just bring in a theory without that kind of gut sense of what's going on in that setting, who the important players are, what the important challenges are, it's very difficult. So a combination of your experience can help you kind of identify the theory and the issues that you need to address in implementing change. So there are many of those. The one that came out of our group, and this came out of Implementation Methods Center funded by the NIMH, John Landsberg was PI, is what we call the EPIS framework: exploration, preparation, implementation, and sustainment. And the main features of this framework is, one, is that it has phases. So it's a way to think about the process of implementation. So in the exploration phase, thinking about who needs to be engaged, how do we bring together the stakeholders and the players important to bring about change. In the preparation phase, you're identifying kind of what the challenges are and how you're going to address those. In the implementation phase, I like to say that's when you find out how badly all your planning went, because that's when issues really start to emerge. And hopefully you've addressed many of those or most of those, but there are always issues that emerge. Things just as basic as turnover of leadership or turnover of staff in an organization, agency, or service system can be critical. And those can have really profound consequences. For example, if somebody at the policy level shifts and it changes kind of the buy-in and support for the change you're trying to make. And that's, I'll just pause, one of the other features of EPIS is that we think about outer context, which really is the socio-political and system level context. So you can think about that as, you know, the state of Massachusetts has, you know, policies that may affect, you know, healthcare and social care. You also may have local system issues, you know, within your city or within a county jurisdiction. So when we think about outer context, it's really that kind of broader policy context. And then when we think about inner context, it's more about what's going on in the setting, specifically where you're implementing change, where you're delivering healthcare. So that could be a hospital, it could be a community mental health center, it could be an NGO or CBO delivering addiction treatment, for example. So there's an interplay of that outer context and the inner context of organizations. And so we try to attend to both of those through all the phases. And then hopefully, once we've implemented, we're getting to this idea of sustainment. So folks that have heard me speak before, I just say it again and again that we really need to begin with sustainment in mind. So we need to begin, it's not just about getting it implemented, which is often the short-term goal of kind of contracts and directives, is that implementation. We want to look further out and think about what it takes to sustain practices in a way that you're going to derive the best public health benefit. So, enough said. So, one of the things about this is in the review that we did, and many frameworks are similar, there are many issues, many factors in this small print on here to attend to. It's up to us as implementers to think about what are the important factors that we want to address. One way to do that is to think about a specific context, your context. So with my colleague, Doug Novins, Doug is Chief of Psychiatry at Denver Children's Hospital and a professor in the School of Medicine in University of Colorado. We did a systematic review looking at implementation factors in child and adolescent mental health. And based on those studies, we were able to winnow down that framework and say, what have people looked at? What did they find to be drivers of change through these different phases? So when you're thinking about implementation frameworks and approaches, it's important to narrow it. And again, this goes back to that issue of really understanding your context, because it's going to be a combination of what the literature says and a combination of what you observe, but also input from your stakeholder groups. And so when I'm talking about scale-up strategies, I really talk about the collaboration necessary to inform your approach and to have folks on board rather than to be the researcher that comes in and says, this is what I think you should do, right? Okay. So we recently completed a systematic review published in January of the EPIS framework. And one of the things that emerged, the EPIS was being used in 11 different countries for all different kinds of health issues in different settings, from hospitals to community mental health to HIV prevention. One of the things that emerged that we're really focusing on now is this idea of bridging factors. So how do we bridge that outer context and inner context? How do we bring the policymakers to the table, the higher level leadership, with what's going on inside organizations and local service systems? And so, one of the ways we do that is through community academic partnerships, through really partnering with our stakeholders and helping to bridge that gap. And then also purveyors and intermediaries. And often we as researchers act as those intermediaries, working between systems and what's happening on the ground to bring about change. And you'll notice in these boxes, we have leadership at the top, both in the outer context and the inner context. And the reason for that, it's not that leadership is some abstract idea, the born leader, the made leader, but there are specific behaviors and actions that leaders can take to signal the importance of a strategic initiative. And that can both be ideological, that can also be very pragmatic and practical in terms of policies that are set, in terms of funding, in terms of engaging with folks across outer and inner context and within those contexts, and finding the right people to help drive change. So for me, in thinking about this, a lot starts with what leaders do and how they act and what they put in place. So, moving from theories to strategies, my background is both in clinical and organizational psychology. And one of the areas that we've been working in is focusing on leadership for implementation specifically. So we brought together theories and ideas from different aspects of organizational culture and climate. My colleague Mark Earhart, who essentially wrote the book on organizational culture and climate with Ben Schneider and Bill Macy, but also building from other fields. And this is something that I think we often don't do enough of as researchers. We get stuck in our own discipline rather than thinking about what's the learning across organizational and management science, across systems engineering, across other approaches that we can bring to think about how we improve care. And so, our work on thinking about what we call the leadership and organizational change for implementation strategy, this work has been funded by the NIMH. We currently have a NIDA trial in implementing motivational interviewing in 60 substance abuse treatment programs in California and Arizona. But the idea here is that we want to work concurrently, with leaders in clinics. Priestland and Hanig in 2005 in the Harvard Business Review talked about when you want to translate kind of organizational ideology and goals into results, your first level leaders are really important, and they're often ignored. So what we hear from clinicians often is, one day I was a clinician, then I got promoted, now I'm a clinic leader, and I got no training. I got training in meeting productivity requirements. I got training in documenting what I need to for our contracts, but not how to lead change and how to lead my staff. So Priestland and Hanig were really talking about these kinds of issues at BP, the oil company, and how these first level leaders, those who supervise your direct service staff, are critical because they're interacting with your staff on a day-to-day basis. So when we started LOCI, we started thinking about that work group level leadership, focusing on implementation leadership. There was no real concept of implementation leadership. So we had work with, funded by the NIMH, my colleague Mark Earhart was PI, to develop measures for these constructs. And so what's happening in implementation science is we have these issues, these constructs, these things we think are important. We may not have good measures of those. So we're in the process of developing those as we go. At the larger level, at the organizational level, we also realized that there was a lack of alignment in what leaders at the top were saying with what the demands were on work group level leaders. And so the LOCI strategy is to work concurrently and bring the leaders of the clinics together with the larger agency leadership. So this is all inner context of the EPIS framework, what's going on within organizations. And then our theory is that we can affect the climate for implementation in those organizations, staff's attitudes, their implementation citizenship, so how they deliver and how they support evidence-based practice, and then ultimately the quality and fidelity with which they're delivering care. But if we take it, so I'll just talk briefly about what LOCI is. So LOCI is a very data-driven process. So it involves assessments before we even start to understand the context of organizations and systems, through web surveys, assessing leadership and climate, and those data are then used to track change. So it's not just where do we stand now, but at 4 months down the road, have we brought about change in leadership? Have we brought about change in climate? Are we seeing things happen? There's didactic training of clinic leaders and booster trainings. And then there's ongoing coaching. One of the things we also heard anecdotally was from folks doing leadership trainings or coming back from leadership trainings is that they had a great experience. And now they got back to work, too many productivity demands, that nice manual goes on the shelf and there's not much change. So even in our pilot work, we were attending to that. So we have these coaching calls that are about 10 to 15 minutes just to keep people tracking about what they're doing. And when we looked at leaders who had that support versus leaders that don't, the differences were striking in terms of cognitive engagement, in terms of behaviors in the workplace and supportive evidence-based practice. We saw big changes in that regard. But the other important part is the organization strategy. And I think this often gets lost when we start talking about this, because people say, oh, LOCI, so you're doing a leadership training, that's great. But it's really much more. It's engaging the larger organization with what's going on in the trenches. There's a disconnect there. And so we want to build that. So that's how LOCI was developed. And we use this idea from Ed Schein, who is a management scholar here at MIT, who talked about embedding mechanisms, what leaders can do to communicate the importance of a strategic initiative to change the climate, the culture of organizations, what leaders pay attention to, what they measure and control. So are they documenting how evidence-based practice is going? Are they providing resources? How leaders react to critical incidents and crises. So if something occurs, do they come back to the support for this implementation? How resources are allocated? Do they role model, teach, and coach? So we had at one of our large agencies, over 1,000 employees, a VP who was well-versed in the practice being implemented, which is motivational interviewing. And in team meetings and in meetings of the agency at large, he would be demonstrating those principles. Allocating rewards and status, and then how leaders recruit, select, promote, and I like this one, and excommunicate. So if leaders understand that there's someone or something getting in the way of implementation of change, of creating this supportive climate, do they move that person to another position? How do they finesse and manage that? And so we've seen that happen in a number of instances where that has to be I'll just say finessed in a way that you value that person, but if they're hindering that implementation, you're able to shift the way people are utilized in an organization or system. So, you know, when we think about EPIS for system and organizational change, we're really thinking more about engaging the system now. And so we're working with one whole state mental health department in the US here, thinking about how we bridge the system with community health centers to bring about change at the clinic level. So, you know, we've kind of identified some of the key things that we think need to be focused on, and we've applied for funding to test this larger model, which looks more like this, where we're thinking about LOCI cross level or at the system level, where we're now going to engage with the clinics and leaders at the clinic level, at the organization level, and the system level. So this really, you know, in the US is one thing when we think about low and middle income countries and other countries. Even I know we have a colleague from Norway on where we're working with LOCI there. How do you engage the system, the health ministry? In Norway, it's the health trusts. In other countries, how do you build that collaboration? How do you build a buy-in to think about sustaining a practice in the long run? So the idea is that if we can bring to bear a focus and alignment through collaboration, communication, the use of embedding mechanisms, creating not only an organizational climate, but a system level climate for the use of high quality and effective practices, we're going to have better public health impact, right? So, and that's kind of where we're going with LOCI, really thinking about how to do that. And it's very consistent with the work that we're doing with the Interagency Collaborative Team model that I'll talk about. So, you know, our preliminary results for LOCI from our cluster RCTs looks good. We're expanding to bridge outer and inner context. And then LOCI is being adapted for other settings. As I mentioned, the Norway health trusts and clinics for trauma treatment in both adult and youth clinics. LOCI is being adapted for schools in the US, thinking about how school districts, schools, principals operate. Community mental health for autism treatment. And then we're also working with veterans hospitals here in the US to think about how LOCI might work in that very complex and hierarchical system. So we have a work group that's kind of hashing out the details about that, thinking about, you know, how we might adapt. So let me just pause there to see if there are any kind of thoughts before I launch
Well, I
into
had one question,
yeah.
Greg. This is really useful, and I think LOCI is so exciting. For those of us who work in really low resource settings, like we have colleagues on the phone now in Sierra Leone and Liberia, where the research question is not how do you scale up and sustain evidence-based mental health care in their health system, because there is not really mental health service available widely beyond private clinics. So one of the questions we're asking in Youth Forward is what are the ways we can bring evidence-based mental health services into new delivery platforms, alternate delivery platforms. And in the case of our study, we're doing that through youth employment, where they are reaching a lot of vulnerable youth, whereas youth normally couldn't get adolescent and youth mental health services readily. So what are the implications for taking some of this great thinking around leadership beyond, you know, the context where you have a service sector to a low resource setting where that hasn't even emerged yet?
Yeah, well, it's really, I think that the strategy of building on youth employment. So if the funders are interested in employment, as you say, building it within that platform is a great strategy, one that can be done through kind of collaboration and negotiation. There are also some other models of bringing practices to the lay community. So I'm thinking of Shannon Dorsey's work in Tanzania around, you know, training laypersons in the community to deliver an evidence-based practice, trauma-focused cognitive behavioral therapy that here in the States, folks thought, oh, well, you need to have a master's or PhD level person to deliver this practice. And so Shannon has proven, in fact, that you can get just as good outcomes with lay workers with the correct supervision. And I think by the same token, the work that you've been doing in Sierra Leone, Teresa, using Caritas and having Caritas providers trained to deliver youth readiness intervention.
Which is cognitive behavioral therapy.
It's cognitive behavioral therapy, right. In a group setting is also you know, sensitive to the needs of that setting and who the potential or what the potential delivery platform is. So it is, it's complicated, absolutely. But a great point, we need to be thinking creatively about how to kind of maximize the effects that we can have. So what I'm going to talk about next is kind of the inception of this interagency collaborative team model that was developed here in the US. And then I'll talk about the shift in how it's being used in Sierra Leone, Teresa's group. So this was developed as kind of an emergent process that came about in San Diego County. And then we were able to get grant funding both from the CDC as a demonstration project and then from the NIMH to really look at the impact of the ICT model. And the idea was, you know, how do we scale up and sustain a practice across an entire service system? And so it became evident early on, and it fit with our theory, that we need to coordinate at multiple levels, both the outer context of the system and the inner context of organizations. But we really wanted a systematic approach and mechanisms for adopting and changing policy as well to address child maltreatment in this case. And so this was in San Diego County, the 6th largest county in the United States, about 1.2 million people in the county. And there was interest from a number of stakeholder groups to address child maltreatment. But we were also thinking about, you know, what are potential hurdles to implementing. And these, you know, types of hurdles really span developed nations and developing nations and systems. You know, so poor match of resources and program requirements. The approach that most systems and organizations use is to train and hope, or if you're religious, train and pray. You know, train your staff and hope that they'll be able to deliver. A lack of focus on quality and fidelity. How do you deal with issues of turnover of staff? You know, turnover rates in human services range anywhere from 20 to 50% annually. So if you've trained your workforce, how do you maintain that? Notable need for adaptation. So how do you do adaptation in a way that really keeps the core elements of a practice or intervention so that it's going to continue to be effective. So, and then a few mechanisms to track and really monitor how Fidelity and the practice is going over time. So lots of things to consider, and these are just a few in that list. So, as I mentioned, there were multiple stakeholders focused on this, and the United Way, a funding foundation, convened what they call a Vision Council to address the issue of child maltreatment in San Diego County. So it really brought together some parents who were in the system, advocacy organizations, provider organizations, the county child welfare system, as well as the local children's hospital. Think about what do we want to address in regard to child maltreatment. And the chart that's up here shows on the bottom from 1994 to 2014, the prevalence of child physical and sexual abuse. The red line at the top is the prevalence of child neglect. Over the course of that same time period, what you can see is an increasing and then pretty steady trajectory of child neglect. And there are more child deaths from child neglect. And it's one of those things that flies under the radar because a lot of times the kids don't end up in the hospital until it's very late in the game. So the decision was to focus on child neglect. And so the Vision Council brought in intervention developers to think about what interventions have the evidence and could be utilized to address child neglect and have a meaningful impact. And then also to think about a sustainable strategy to scale up across the entire service system. And as I mentioned, then we obtained some funding. We were part of the Vision Council and then obtained funding to really look at the
Can we go to that slide? What was the slide before? Why was there a dip in that? Was there any reason why there was a dip in that year?
I don't know offhand why there was a dip. I mean, it could be anything from reporting to actual change. It was probably more in reporting, I would think.
It's interesting that there's a dip for physical abuse as well as neglections.
Right.
Yeah. Somewhere around 2000 looks like.
Yeah.
Yeah.
And they changed the data collection policy,
Often
you
that
know.
happens, yeah.
All right.
Okay. So the practice that was selected is one called SafeCare, developed by John Lutzker at Georgia State University. And it was selected for a number of reasons. One, it focused on child neglect. Number two, it's a home-based service. The child welfare system and many child welfare systems have existing home visitation platform. So how do you build it into an existing platform, as we were discussing, thinking about Sierra Leone as well. And that providers don't need to have an advanced degree, that mostly bachelor's level providers could deliver this. Focused on building foundational skills for parents, problem solving skills in a very structured way, and communication skills. So it's really trying to build up parents in parenting. And then focusing on 3 content modules, health of the child, and often, parents, in the child welfare system, they didn't have really a good idea of how to document their child's health, how to talk to a physician about it, how to determine whether a problem was something they could treat at home. They often would just go to the emergency room. So could they treat at home? Could they just call a doctor or nurse and get advice? Or is it something that was emergent and needed help? The other module, home safety, focused on going through the house and looking for hazards in the home. And so who knows what the most frequent source of poisoning is for kids? Anybody? Things that smell like fruit and candy, shampoos, cosmetics, things like that. So even kind of going through the home, looking in the cupboards. I mean, in the United States, unfortunately, we need to think about, where are the guns and ammunition kept? Are those safe from kids? So it's really developing those skills with the parent to monitor the environment as well as their child's health. And then focusing on bonding and attachment through parent-child and parent-infant interaction. So things as simple as, talking about what you're doing while you're carrying your infant around the house. Now I'm taking clothes out of the dryer. And look, I'm folding this shirt. I'm folding it in this way because just that kind of stimulation and bonding and relationship. So really kind of foundational stuff that we often take for granted, but that many of our young parents don't really, they've never received that support. So, there was a training curriculum, 4 to 5 day training. And then one important aspect of this model when we think about the ongoing Fidelity is it uses coaching. So the trainers are also coaches who once a month go out to the home with a home visitor and observe them, role model, give pointers, and coach. So it's kind of built into the process to have that. But one of the things that we're really thinking about with the ICT model was, how we can develop local expertise. And so in this particular instance, what we had was this idea of developing a seed team, right? So the intervention developers were in Georgia State. The ICT Collaborative was able to negotiate with the intervention developers to say, we want to have local expertise here. We want to train a local team to be able to train staff, to have the capacity to coach staff. And then if we have turnover, they can also train new cohorts of providers as we have the need. So that's where this idea of the seed team building local capacity was important. And then the intervention developers would slowly pull out with maybe an annual recertification or something like that. But something important to note in this model is that, we had the United Way who said, we're interested in kind of developing this and working with you. And this was a real shift for that foundation. Previously, they had done things like giving a $10,000 grant to print pamphlets about shaken baby syndrome and put those in a pediatrician's office for parents to see. And the impact of that type of strategy was very limited and just really unclear. So this was a big shift for the foundation as well, to think about how can we have a lasting impact and how can we support the scale up, initial scale up. But there was a lot of, we call it a collaborative model, but there was a lot of negotiation also between the United Way, the community-based organizations, and the child welfare system to say, how are we going to then shift responsibility for maintaining this practice in the system? For the county, it was kind of a win-win because they already had the home-based platform. They're already funding those types of services. So they really were, for them, having the United Way come in and say, we're going to support the initial training was a real win for the county. And for the United Way, it was a win because they don't have to keep funding it forever. So it's kind of that shift. And so the way it was going to roll out was to have the C team trained by the intervention developers. The C team begin training one team here, and then consecutively rolling it out across the county. So the research design was what we call a non-inferiority hypothesis, right? Could we maintain high levels of fidelity as we roll out across the system, as the training and support are being done, not by the intervention developers, but by your local team. So it's a way of saying, can we get that local capacity and really support it over time? So things happen. We use the EPIS framework, of course, here, which was really helpful in the staging of the process. So in the exploration phase, identifying and convening the stakeholders, that vision council, bringing in the expertise about the EBP alternatives. So really 3 different intervention developers came and presented, and then SafeCare was selected. And then developing commitment to the change effort from the United Way, from the system, and from the community-based organizations who would be contracted to provide care. And they were already providing the home-based care. Now it was adding this dimension of the evidence-based practice. So the selection process and identifying the initial ICT members, and the Interagency Collaborative Team works in a number of ways. So it works within the C team, because there were staff from multiple local agencies. So the idea was that you're immediately distributing knowledge about the practice across the local agencies. It doesn't reside in just one agency. But the Interagency Collaborative Team was also at the system level. So it was the system leaders, it was the community-based organization leaders, along with the academic partners. All of us together were kind of an interagency team and had that need to collaborate through the process and that desire. And so in preparation, funding the C team positions and formalizing the C team role in the system-wide CBO and contracts. So a lot of this had to be hashed out, not just ideologically, but in terms of what would a contract and what would funding actually look like. And there were negotiations about that, which I'll talk about in a minute. And so the C team was trained by the EBP developers to high fidelity. Any adaptations of the model were jointly monitored by kind of the local C team and the developers, and pilot and finalize the adaptations. And finally, our local C team training cohorts during the rollout, providing that fidelity support and coaching, and also developers progressively pulling back as we went. And then the C team still worked with the intervention developers, but less frequently, training new cohorts for turnover, provide in vivo coaching, and assisting the CBOs and system leadership in troubleshooting challenges. So that's where we are. We're about 5 years out now that the model has been sustained with fidelity. And I'll talk about how we know that there is fidelity in just a minute. But the study was a mixed quantitative and qualitative because we wanted to understand what happened with fidelity, but we also wanted to know what the process was for this implementation and scale-up strategy. So as I mentioned, it was the term collaboration. It brings that kind of around the campfire, holding hands. Isn't this great? We're all collaborating. But really when stakeholders came to the table, there were some kind of dicey and uncomfortable negotiations and challenges as folks had to advocate for what they needed in order to be able to participate in this. So for example, one of the seed team CBOs that was involved said, well, this is all fine, but what are we going to do in order to serve our clients while we've taken staff offline to be trained in this practice? And we really need the contracts to support that backfill as we go forward. So those were somewhat tense negotiations that had to be done. But the system was able to get through those through this collaborative team model. And I think having multiple stakeholders at the table helped with that. A lot of that contract negotiation was in the open. The entire collaborative nature of the county and the CBOs were involved and understood that those issues were going on. But things like different organizational cultures and approaches, competing priorities, and role ambiguity. So it was also a process of clarifying what the United Way would do, what the county would do, what the CBOs would do, what the seed team would do, and how they all interact. So we called that the collaboration, negotiation, coalescence process because it really came together. And then, back in 2016, the Nobel Prize for Economics was awarded to 2 researchers who studied contracting and contracts. So we've been focusing a lot on the nature of contracts and what they can do in terms of implementing evidence-based interventions and what's the nature of both the contracting process. Some processes can kind of scuttle evidence-based practice, and other processes can be more egalitarian. So for example, there's one public sector system that we worked with that was going to use a new process where the proposals were limited to 6 pages, where organizations used to be able to submit a proposal, 60 to 100 pages describing, the organization, what they can do, their capacity. 6 pages were 2 pages on risk mitigation, 2 pages on the practice that you want to implement, and 2 pages a description of the organization. The contracting groups at the state level loved it, but actually it almost led to, this is a whole other statewide system, almost led to a practice that had been sustained for many years being scuttled. So we're looking at the contracting practice as well, but contracting done right can create that climate for a practice, can support institutionalization of a practice, so statements of work specifying expectations and requirements, and signaling, as I mentioned, the implementation climate. And we just have a couple quotes. You know, what we know now, we would have put explicit language in terms of expectations around implementation. And I have a doctoral student from USC that I'm working with who is reviewing 142 contracts from 11 different service systems that all implemented the same practice to look at the nature of contracts and which contracting practices and approaches lead to better sustainment of the practice. So we're really trying to understand that. And so part of what we did with this project was also measuring fidelity. And so it's one thing to have our coaches go out and do in vivo coaching, but we're trying to determine ways to assess fidelity on an ongoing basis. So our group developed a fidelity checklist. At the end of the session, the home visitor hands a tablet to the client, and it's about a 1-minute checklist. The tablets are already programmed. We know what module, what session, and we're able to calibrate that with the coach observation on a limited number of sessions. And so we have a good sense of fidelity as we go forward. And what happened with this is, as the NIH grant ended, the service system came back to us and said, we really value the system. Can we contract back with you to maintain it so that we have, it's almost real-time feedback on fidelity so that they can know how staff are doing. And this is a huge issue when you're going to scale. It's how do you know how the practices are going? So what we're able to determine in our first cohort and second cohort is that variability in fidelity of the C team at the top was very similar to the first cohort in the rollout, and that there was no significant difference using a non-inferiority approach is different than testing for a significant difference, but we were able to show that they were essentially equivalent, the fidelity of the C team with the rollout of the first group. And so now we're looking at multiple cohorts down the road to see how that pans out, and it's looking pretty positive. And so this really has led to the ICT project to continued collaborations. We now have some funding from the WT Grant Foundation to think about how we can instantiate and increase the use of research evidence in policy and policy decisions and in practice. And so that's our community academic partnership for translational use of research evidence. And we really have maintained that technology platform. So now we want to talk about, with the time that we have
5 minutes, yeah, and then we'll have 5 for questions.
Okay, is the ICT adaptation for Youth Forward in Sierra Leone. And this has been a wonderful opportunity for me to work with Teresa and the group here through her Unite team, the Global Mental Health Scale-Up Hub in West Africa. And so Teresa's focusing on, and the ICT there is focusing on adversity and inequality in Sierra Leone, and mainly on youth, adolescents who've experienced trauma related to the Civil War and the Ebola crisis, who really need help in terms of kind of employment and stability that requires both mental health intervention, improvement in their ability to, kind of emotional regulation, and their ability to be gainful members of society, whether that is kind of starting kind of an own small business or joining employment. Teresa and her group have developed the youth readiness intervention. You hear a lot about common elements interventions now that kind of bring together elements from effective practices. And it's also a transdiagnostic, so it addresses multiple mental health and behavioral health issues of youth. So it's very it's strategic in its use of elements to address multiple issues rather than focusing just on one narrow issue for youth. And so the idea is, this idea of building capacity in alternate delivery platforms and thinking about creatively about how those models can be used in West Africa, but not just in Sierra Leone, but I think it's serving as a model for other countries as well. And so it's the U19 Hub is funded by the NIMH, but it's important to have an employment partner. And at first that was the World Bank, and this is another issue of implementation where you have to be able to navigate, negotiate the changing landscape. So there were changes at World Bank that led to the need to really change the employment partner, and Teresa was able to identify a group called GIZ that also can help support this process. So I won't say it was seamless.
It took a lot of work.
Yeah, it takes a lot of work to make that change. But the goal is to use the Interagency Collaborative Team model to scale up. And so that this issue of the who's in the collaboration, within health ministries, within your employment partner, within mental health, within your NGOs in country, that all becomes part, and those players all become part of that interagency collaborative team. So it's not just the seed team. And so for Youth Forward, it's really thinking about, the players working to identify the expert seed team, becoming supervisors, training the new seed team to deliver, identifying agencies, the facilitators, training of expert seed team members, and the seed team delivering the YRI and assessing fidelity as you go forward. So it really is a very cyclical process. And I think we're really happy also that the NIMH has been helpful and supportive through this process, understanding what it takes to really implement in low and middle income countries. So another thing that I think is great is that the language of the EPIS framework has been adapted for Sierra Leone. And the idea of outer and inner context didn't make sense, but the outer circle and inner circle of what's going on resonates more. And so these kinds of even language adaptations to fit those settings is really important. We can't be seen as like bringing these really foreign concepts that don't make sense to folks. So that's also important. And you can see in the outer circle and inner circle factors change over time. So in the exploration phase, you may have certain things that you focus on, and that may change in the preparation, implementation, and sustainment phases. So it's important to think about what's important in the outer and inner circle as you move towards sustainment over time. And building on we had a dynamic adaptation process. One of the things that's really important is that the implementation resource team is really your larger implementation kind of ICT, right? That comes together. And you can see here, it's slated to involve the system and leadership team, co-investigators, the in-country team, including the program managers, the NGOs, the health ministry, if you can get buy-in, YRI facilitators, and the seed team. And it's really a problem-solving approach that you have to use in moving through the implementation phases. And so, there are kind of demands and requests from NGOs to create this, including direct service staff, centralized training, doing the subsequent training, and involving and establishing the ICT in this case, Caritas, and additional NGOs in contracting and subcontracting arrangements. So I think we'll
we could open it up.
I think we can go for questions.
Yeah, 'cause I think This is still in process. Tyrone and I will be working on a paper adapting the EPIS framework for low resource settings and humanitarian affected settings. But I know we have a lot of people online as well as in the room, so let's open it up to a few questions. In the room, do we have online questions?
Not yet, but you can feel free to either unmute your microphone or type it into the chat if you do.
Okay.
Quick,
Yeah, go ahead.
question. So, thank you so much, Greg, for this presentation, and I really like the EPIS framework being, kind of applied both in the domestic and in the international settings. One of the key points in implementation science in general, and also the frameworks, I know that has done a lot of work on understanding different kinds of framework. One of the points that I really wanted your thoughts on is, especially in this EPIS framework, if at all we have to understand the implementation phase and the sustainment phase with regards to time, how do you do that? When do you call an EBI to be in the implementation phase? And after which, what time period do you say that now it's actually gotten into a sustainment phase? In my area of work, in clean cooking in under-resourced countries, I really struggle with this question on and across different kinds of frameworks. Could you?
Yeah, great question. And so if I had 2 hours, there was a study here in the US called JJ Trials. It's for juvenile justice youth who have alcohol drug needs. And so the EPIS framework was used there. That was 6 funded NIDA centers and a coordinating center, very big project. The group identified specific transition points between each of those phases and worked with Lisa Saldana, the Oregon Social Learning Center. So she has a measure called the stages of implementation completion. And through a process of working with Lisa and mapping onto the EPIS framework, we identify those transition points. So what's been accomplished in each of those phases. And it's a matter of documenting kind of what is supposed to occur, how long you spent in each phase. And then, so for example, moving from implementation to sustainment, you might have a threshold for achieving fidelity of a practice. And if an NGO as a team achieved acceptable level of fidelity, then you move from the implementation to sustainment phase. But it's a great point, and I think that often in these studies, we don't do a good enough job of identifying that. So yeah, there's a paper by Jen Buchan out of Texas Christian University that describes how the JJ Trials group went about that. So I think that could be helpful. Yeah.
Thanks.
We have a question from online. Amit Mistry is asking, were there any elements of the EPIS framework that did not work well in Sierra Leone?
I think EPIS is broad enough. I'll answer and then Gregory can tell me. EPIS is broad enough that we didn't ever find that elements didn't work well. We just had to, if you go back to that model where I adapted it, we had to put in whole new places where you're starting, because you're not starting in a service sector where they're doing mental health and now you're saying, well, how about you all do evidence-based mental health? They were not doing mental health services. Yeah. So if you see here under the inner circle working with the agencies, we had to sell the win-win. So we had to go to those agencies and say, you care about youth employment, you care about human development and youth who are affected by conflict thriving, mental health matters. And we have tested this mental health intervention, and for you to achieve your outcomes of youth employment, like young people being able to take up your trainings on how to be pursuing a livelihood, we can't ignore the trauma they've been through. So we'd have to sell the win-win around buy-in engagement from the very beginning.
Right, and so that gets at, creating that climate for the use of the practice. How are you demonstrating the importance? And sometimes it's creative reframing to meet the needs of your in-country partners. And mental health in much of sub-Saharan Africa is not very high on the radar. So I think this is a really great creative example of how you build it in to the needs of the community so it can get some both ideological and some funding support.
And then funding wise, you don't have a service sector with the county giving subcontracts to all the CBOs. You have a Ministry of Health with almost no budget. you know, NGOs one at a time doing their own small thing, but not really a place where you can have referrals. And so to get funding for the youth readiness intervention, we had to negotiate with GIZ, the German Development Agency, about this win-win. They had a psychosocial component to what they wanted to do, but they weren't using an evidence-based practice. So we could say, oh, well, you have realized the importance of this, we agree with you. Would you be interested to scale up this evidence-based practice as that psychosocial component? And that was the nature of that negotiation. But even with that, like as you see here, the support tied to short-term tenders is something we learned about in the preparation phase, that even though they are willing to do the contracts to fund for the service, including psychosocial, these are not years of service, these are for months at a time. So that's a huge problem for sustainment.
Yeah, thinking about how you can get the continued funding and support.
So,
and then if you have, I mean, similar to what we have, you know, if you have changes in top leadership, a new election and changes in funding, that can affect. So, you know, we talk about institutionalization. What are the ways that their practice can be institutionalized? And the more things that can be put in place that can't be scuttled. And in our studies of leadership, system and organizational leadership for sustainment, you know, it's those leaders who were thinking ahead, who were instantiating policies that were more difficult to change down the road and putting teeth and mechanisms for those policies to provide funding and support. Those were the more successful in sustaining practice 2 to 10 years down the road.
I can't agree more that you have to think of it from the very beginning.
From the beginning.
From the very beginning. And a lot of our CTs just think, well, does it work? And that's it. So the hybrid designs really are looking at those implementation questions concurrent to the effectiveness questions, or one or the other, and how you sequence it. It's really great.
Actually, I have a question. For the self-care home-based intervention, you talked about the C teams, and that after 5 years, you saw Fidelity after the intervention, the study was over. Am I correct with that assessment?
Right.
So my question.
We're looking at that next across all the cohorts, but
so,
we are seeing Fidelity. Yeah.
Great. So my question is, for the C team, are they still meeting? Because my concern, or our concern about Sierra Leone, when we're looking about sustainment or scaling out, is that definitely having a learning collaborative or a C team will be very essential in doing that. But at what point, or because you have a study, you develop these relationships, the C team is formed, and it's consistent throughout the course of the study, and then the study ends, that means the money ends and the support ends. And there is an investment for the individuals within the C team, but that added component of that financial support, not that they are getting paid to be a part of C team, but they're getting support to get to meet together.
Right.
I think it's probably not a question, more.
No, but I think
No,
the
I think it's
issues of
something to think
financing
about.
and
Because that's the same.
which partners are at the table is
And that's the same, that's even more prevalent in low middle income countries, but it's even here in the United States. If you want clinicians to continuously meet after they get stipends for filling out observation forms.
Right. So
very limited. So I'm just wondering, like,
so that's why I would say begin with sustainment in mind.
Right.
And think about how it's going to be sustained. And I think the ICT is a really aspirational model, but it's been demonstrated that it can work here in the US if the system is thinking, we want to sustain this long term, this isn't the flavor of the day. And the support for the practice and the implementation of the practice was not, it didn't come from the research grant. The research grant was entirely just the research process. So we have a question from Thomas in Norway. Do the ICT teams, C teams, have designated positions solely focusing on implementation support? Are they practitioners or middle managers doing this part-time? If not, do you believe that would have been a feasible model? So the way the C teams have been working is the trainers and coaches have that responsibility for the training and coaching, but it's not always full-time. So they also supervise other practice and in some cases see clients as well. So they're utilizing their time as efficiently as possible and not saying, oh, you can just sit at your desk and wait for the next training. They're really engaged in the system and delivering care. And I think, are
I
we?
think
I think we're out of time.
Yes, so thank you so much,
Okay.
Gregory,
Thank you,
Aaron, so
everybody.
much.